நம்மலாம் as children நம்ம எப்படி இருந்தோம்ன்றது சொல்றோம். செம காமெடி. இவன் வந்து இந்த சிப்பர் பாட்டில் நீங்க குடிச்சிட்டு இருக்காங்க வேணாம் அப்படின்னா வந்துட்டு அப்புறம் கேட்டா லட்சுமி அக்கா பரவாயில்ல விடு என்ன பண்றது நான் சந்தீப் சொன்னோம் இது மாதிரி பரவாயில்ல வீட்டுல இருக்கு வெளில இருக்கிறவங்களோடய போய் இதைத்தான் பண்ணிட்டு இருக்கு அப்புறம் அவ வந்து இதுதான் சொன்னா என்னது அவ டிஃபன் பாக்ஸ்ல வந்து பார்த்தா எல்லோ எல்லோ வந்து மஞ்சள் பொடி
Good evening, everyone. So, thank you all for joining for the next in series webinar. So, I'm sorry for the delay due to certain personal and health issues. I was not able to do it. So, today we'll be talking demystifying aminoglycosides. And there has been certain technical glitches on my end, like my laptop has crashed. So, I wanted to the polls won't work. So, I would request all of you to comment your answers in the comment section. So we'll just wait for another 3-4 minutes before starting. I hope I'm audible and there's no fluctuation in the network. Okay, it's 6:05. So let's start with today's session on demystifying aminoglycosides. We'll start with a case. A 47-year-old man cuts his thumb while attaching an accessory to one of his machines. The next morning, his thumb is sore and the skin surrounding the cut is red. The next day, you notice that the thumb is swollen and throbbing, and there is some yellowish white pus which is oozing out of the injured area, for which he does the dressing at the home. Following day, the man experiences shaking, chills, and becomes queasy. He is taken to the hospital. On examination, he is febrile, he is flushed, ill appearing, with a pulse of 125, and his BP is 90/60. What is the next line of management? So, what do you think is the likely diagnosis in this case? So, I request all of you to please comment put your this one in the comment section. Three. Okay, most of you have got it correct. So that is yes, the patient is having sepsis secondary to the wound infection. So what is the next best step in the management? There can be multiple correct answers, or it can be all of the above. Do you want to draw blood cultures, initiate antibiotics, do fluid resuscitation, pus culture, blood lactate levels, send CBC, and any biomarker you would like to send? All. Yes, most of you have again got it correct. So yes, you will have to do everything. So in any patient who is presenting with sepsis, you need to send the blood culture before starting the antibiotic. And there's a 1-hour bundle which says you have to do the resuscitation as well as initiate the antibiotics. Blood lactate level you will be you have to send, and CBC for monitoring. And so 1-hour bundle in sepsis includes IV fluids, that is a crystalloids. You have to give at least 30 ml per kg within 3 hours. And this should be guided by the dynamic measures of fluid responsiveness, signs of fluid overload, and urine output. And you should target the MAP, mean arterial pressure of 65 mmHg. And resuscitation should be guided based on the blood lactate. So you should look at the lactate, and you should target the reduction in the lactate. And the use of biomarkers to initiate an antibiotic is not recommended alone. So if you are clinically suspecting the patient is in sepsis, you can as well start. And so what empiric antibiotics would you like to start in this patient? There can be multiple correct answers. So let's see, the patient is having some wound infection, and there is some pus, and the patient is in sepsis. What would you like to do? What antibiotic would you like to start? So this patient is in sepsis, and they secondary to the wound infection. So the ideal thing would be based on the patients. You add further history is required, whether the patient was previously admitted anywhere, there is any other reports where there is isolation of any MDR organism, and depending upon the severity, the patient is in sepsis and not in shock. So this brings us to the surviving sepsis campaign. So the antibiotic timing and the choice depends on whether the patient is in sepsis and whether the patient is in shock. So our patient is not currently in shock, and sepsis is definite probable, or is definite or probable. So in that case, you have to start the antibiotic immediately within 1 hour. If there is no shock present and the sepsis is just possible, you can wait up to 3 hours, and you will have to do the rapid assessment of infectious versus non-infectious causes of the acute illness. So the antimicrobial choice depends upon various things. First is the risk factor for MRSA. Is it there? So the risk factors for MRSA include prior history of MRSA, recent IV antibiotics, recurrent skin and soft tissue infection, and invasive devices, hemodialysis, and previous any hospital admission. In that case, in such situation, you will have to add the MRSA coverage as well. In our patient, according to the history, there is no mention, so there is no requirement of MRSA coverage in this patient. But again, the patient's scenario, wound infection, commonest causes of wound infection includes your Staphylococcus aureus, your Streptococcus, Enterococcus, etc. So you'll have to give some gram-positive coverage in this patient. Next, what gram-negative or coverage will you give depends upon the presence of risk factors for MDR organism that is proven or colonization with MDR organism in the previous year, whether the patient had broad-spectrum antibiotics within 90 days, concurrent use of um, uh, digestive decontamination, hospitalization within prior 90 days, and local prevalence of the MDR organism. So in our patient, depending upon your hospital, whether there is high risk for community acquired MDR and whether these patient is coming to you with all these risk factors, you will decide to give MDR coverage. And according to the surviving sepsis, they are suggesting at least 2 antimicrobial in case there is presence of any MDR organism. So this combination of the two antimicrobial, so one of which can be depending upon the type, you can either start on meropenem or you can give ceftriaxone plus aminoglycoside, etc. And this is a specific recommendation where they're suggesting to use prolonged infusion of beta-lactam over the conventional bolus, and we have to look for the source of the infection, and adequate source control is recommended as soon as it is identified. And prompt removal of the if at all you're suspecting any CRBSA or the intravascular access device related infection, that should be removed. And there is suggestion for de-escalation, and if the patient is not found to be having any further sepsis features further, and the duration of antibiotic, there is a recommendation for using shorter over longer duration. So just I wanted to give a brief overview of the surviving sepsis as well. So this brings us back to the topic, what are aminoglycosides? So aminoglycosides, so how were they discovered? So they Waxman, he observed that MTB organism was destroyed when soil was applied on them. So when he analyzed the soil, he found that the soil contained actinobacteria, and that is from where these aminoglycosides have been taken from. So the first aminoglycoside was discovered was streptomycin, and it was in 1944, and Waxman was given Nobel Prize for this discovery as well. And how are we going to name? So if the name contains mycins, My, that is derived from streptomyces species. If it contains Mi, mycins, it is derived from micromonospora species. Coming to the chemistry, as the name suggests, aminoglycoside. So it has a 6-membered ring with amino group, and that is the aminocyclitol. And along with that, there are certain glycosidic bonds. The exception is pectinomycin, which has this ring, but no amino sugar or the glycosidic bonds. And these are highly soluble in water. So what does it mean? So if it is soluble in water, it will be less soluble in the inorganic fluids. That is why it cannot cross any lipid containing cellular membrane. So these are the various structures of the various aminoglycosides. There are various chemical families. So streptomycin family contains streptomycin, kanamycin contains amikacin, kanamycin, tobramycin. Gentamycin family contains gentamycin, netilmycin, cisomycin, and the newer aminoglycoside, plazomycin. Neomycin family consists of ramacetin, neomycin, paramomycin, and spectinomycin consists of spectinomycin. Coming to the mechanism of action, so basically there are two main steps in the action of aminoglycoside. Transport of the aminoglycoside through the cell wall and the cytoplasmic membrane, and then binding of the to the ribosome, resulting in protein synthesis inhibition. So all of you know that these are aminoglycosides are protein synthesis inhibitor. So how exactly is it acting? So they diffuse across the outer coat of the gram-negative bacteria through the porine channel, and they enter the periplasmic space, and it is carrier mediated, which is linked to the seed. And then depending upon the various aminoglycoside, streptomycin binds to 30S, and others will along with 30 yes, it can bind to additional cytosine 50S as well. So what happens once it binds? So it will block the initiation of protein synthesis. So they specifically bind to A site on the 16S rRNA, that is a component of S30S. So what happens because of this? There is the genetic code will be misread, and hence there will be the translation will be interrupted, and there will be block of the protein synthesis. So this brings us to the next important question. What are aminoglycosides? Are they bacteriostatic or bactericidal? What are they? Please reply in the chat box. One, bacteriostatic. So few of you are answering bacteriostatic. So these are one of the protein synthesis inhibitor, which is bactericidal. So all of you would have heard that if it is acting on cell wall, it will be bactericidal. Whereas if it is acting on the other areas like protein synthesis inhibitor, usually they are bacteriostatic. So what makes it bactericidal? So how is aminoglycoside a bactericidal agent? So as I mentioned, the initial site of action occurs in the outer bacterial membrane. So these are positively charged. So what happens? This positively charged antibiotic will competitively displace the cell wall magnesium and calcium bridges. And this leads to formation of a hole in the membrane and leakage of the intracellular contents. And this also will enhance the antibiotic uptake. And because of this action, it is bactericidal. And this entry of an aminoglycoside into the cell requires energy. And these anaerobes will have very less energy which is available, and hence aminoglycosides will not be acting on anaerobes, or they are intrinsically resistant. So aminoglycoside acts on all except, does it act on E. coli, Pseudomonas, NTM, Streptococcus? So please use the chat box. Four. Yes, most of you have got it correct. So the spectrum of the aminoglycosides are mostly aerobic and facultative anaerobic gram-negative bacilli, which includes your Enterobacteriales, Pseudomonas aeruginosa, Acinetobacter, can act on your as well as your Serratia, etc. And it is intrinsically resistant, as I mentioned before, and anaerobes. As well as your most of your gram positive, it has some action on MSSA, but it does not have any action on MRSA. And all streptococci, including Streptococcus pneumoniae, Enterococcus, in gram negative, it is intrinsically resistant against your Stenotrophomonas, Maltophilia, and Burkholderia. And there is a very less intracellular concentration of the antibiotic aminoglycoside. So it generally should not act, but it has been used as a therapy in intracellular organisms as well. So this is the spectrum of action. So it can act on Enterobacter, Pseudomonas, Acinetobacter, Aeromonas, and gram-negative bacilli. Gram-positive, though it is intrinsically resistant, the important property of aminoglycoside is that it has synergism. So that is why these have been used in synergy with the beta-lactam for treating gram-positive infections as well. And other organisms, atypical organisms, which it has action on are Mycobacterium tuberculosis, NTM, Brucella, Bartonella, Tularemia, Yersinia, and one of the drug of choice for your nocardia as well. So the next important thing in any antibiotic is the PK/PD. There are three important properties of the aminoglycoside you should know. They are rapidly bactericidal, concentration dependent. They have a prolonged post-antibiotic effect, and they have good synergism. So any aminoglycoside, whenever you're talking about PK/PD, these three are very important points we should always remember. And the optimal bactericidal concentration is when it is 8 to 10 times above the MIC, and it has a low protein binding, and high water solubility, and hence, so it has low protein binding. So it will distribute freely in the vascular space, and most of the tissues and body fluids, it will attain good concentration, but it has reaches subtherapeutic concentration in your CSF, vitreous fluid, prostate, and brain. So why is it so? Because these are the areas of where there is a lipid membrane. So the aminoglycoside, they are relatively large in molecules and cationic, and they do not pass the lipid membrane, and hence they attain very low concentration. They are poorly absorbed in gastrointestinal tract, and hence almost all all the aminoglycosides are given parenterally. And the primary distribution of the aminoglycoside is the extracellular fluid. That is why what happens in patients who are in fluid overload, or there is in patients with sepsis, when we are pumping in so much fluid, and the patients who are having renal dysfunction, obviously you'll have to do the dosage modification. It has good penetration in the bones, synovial fluid, as well as the peritoneal fluid. And as I mentioned, it is highly water soluble and insoluble in the organic solvent, and hence it has poor membrane permeability. Intracellular concentration are usually low, but it, with the exception of the proximal renal tubule, and as I mentioned, it is the cationic or the positive charge which is contributing to the antimicrobial effect, and that is the thing which contributes to the toxicity or the adverse effects as well. And hence, the activity is enhanced in alkaline pH and is reduced in acidic pH. So all of these points are very important because all of these points have treatment implication. So this is the overview of all the PKPD parameters. As I mentioned, over a poor oral absorption, a bad low protein binding, T-half is around 2 to 3 hours. CSF blood penetration is quite low, and it does not attain good therapeutic levels in the CSF. And it is a pregnancy class D. Why? One thing, because of the risk of ototoxicity in the neonate. Coming to the resistance, the bacterial membrane, the resistance can be either of the three mechanisms, by the membrane alteration leading to the, or due to the altered binding or reduced uptake or active efflux, decreased aminoglycoside binding, and enzymatic deactivation. This is by the aminoglycoside modifying enzymes. So these are one of the most common cause of aminoglycoside resistance. They belong to three subclasses. Aminoglycoside N-acetyltransferase, or called AAC, aminoglycoside O-nucleotidal transferases ANT, and aminoglycoside O-phosphotransferases APH. So all these, basically, they are the enzymes which will just destroy your aminoglycosides. So now I have another case. A 63-year-old man is admitted with a 9-day history of fever, and he was prescribed levofloxacin OD by one of the doctors, and the patient is not seeing any response, and he is having persistent fever. And medical history, when you are on evaluation, it was found to have, he has had aortic valve, aortic root and ascending aorta replacement via Bentel procedure, and there is a mechanical valve prosthesis 4 years back. On admission, physical examination was unremarkable. Chest X-ray was normal. Blood test shows slightly elevated WBC. Creatinine is 1.3 and CRP is 12. Blood cultures were sent, and all of the 6 bottles grew Enterococcus fecalis, which is susceptible to ampicillin with high-level aminoglycoside resistant. So what is your next line of management? So what syndrome are you considering in this patient? I want answers. So the patient is having some history of, there's a cardiac history and there's a prosthetic valve in place, and there are 6 bottles. So you should always think about infective endocarditis. So Enterococcus infective endocarditis. So whenever you're clinically suspecting infective endocarditis, the next important step is doing the proving the endocarditis. That is by transthoracic echo. And in case the patients, if there is still high suspicion, and you can also go for transesophageal echo. And this transesophageal echo can also be useful in better, it has better sensitivity in prosthetic valve, and also it is better to do in patients who you are suspecting right-sided endocarditis. So what is the next level of management in this patient? So as I have said, it is Enterococcus fecalis, which is sensitive to ampicillin and has high level aminoglycoside resistance. So what is the implication of this? So what would you like to start the patient on? So let's see. 4 vancomycin, 2. Okay. So 2 ampicillin plus gentamicin. Okay. So what does this high level aminoglycoside resistance or high level HLAR or SR? So basically, as I have mentioned before, Enterococcus is intrinsically resistant to aminoglycosides. So why are we looking at this aminoglycoside resistance here? So this is what we are looking at is a high level aminoglycoside resistance, and this is different. And this is because there is a synergism between a beta-lactam and an aminoglycoside. So basically in Enterococcus, the aminoglycoside can't enter. So what beta-lactam is doing is, it is creating holes so that your aminoglycoside can go inside and have the action. So based on whether the susceptibility of the high-level aminoglycoside as well as the beta-lactam will decide the treatment. So if the HLG is sensitive or susceptible and your beta-lactam is susceptible, the synergism will be present, and you can give either penicillin or ampicillin depending upon the susceptibility with gentamicin for endocarditis. So you please remember, this is only for treatment of enterococcal endocarditis, not for all the all enterococcus infections. And also please remember, high level, whenever you're reporting high level gentamicin resistance or susceptibility, it doesn't mean you have to give high doses of aminoglycoside for the therapy. It is a usual dose only. And now suppose HLAR, that is high level aminoglycoside is resistant, and but your beta lactam is susceptible, like in our situation, there won't be any synergism. So the drug of choice or the treatment of choice will be ampicillin plus ceftriaxone or imipenem. So in this, ampicillin plus ceftriaxone will be the treatment of choice. If there is high level aminoglycoside sensitive, with your beta lactam resistance, and again you have to look at whether it is high level or low level. If it is low level resistance, that is if the MIC of penicillin is between 16 to 64 and ampicillin is between 16 to 32, synergism can still be present. Here in this case, you can use high dose beta lactam, that is penicillin or ampicillin with gentamicin. Next scenario is high level resistance of beta lactam with HLG susceptible. That means in this scenario there won't be any synergism, so you will have to go for no other option. You have to go for vancomycin plus gentamicin. Again, you remember vancomycin is also one of the nephrotoxic drugs. So when you're giving with gentamicin, the nephrotoxicity is much increased. So you can instead give vancomycin with ceftriaxone as well. So this is one of the very important topic I wanted to discuss, is the dosing of aminoglycoside. So the aminoglycosides are not very simple to use. You will have to dose effectively. There were 3 strategies which were used. One is the extended interval dosing or the single day daily dose. Next is the traditional dosing. The traditional dosing was giving Q12 hourly or Q8 hourly even. Then is the synergy dosing. So whenever you want to determine the dose of aminoglycoside to be given, you first need to determine the dose as well as look at the creatinine clearance of the patient. And you have to use total body weight in underweight and non-obese patients. And in obese patients, you will have to estimate by using the adjusted body weight. The adjusted body weight is ideal body weight plus 0.4 into total body weight minus the ideal body weight. So for the height of the person, what is the ideal body weight you determine, and then you find out the adjusted body weight, and you have to determine the dose of the aminoglycoside based on this. So there is no universal dosing regimen. It has to be individualized, and you have to do the calculate the creatinine clearance. Why are we looking at once daily dose? Because it was found to be as efficacious as well as the traditional multiple dosing, and for the toxicity, it is much lower, and it is easier and less time consuming and more cost effective, and even it does not worsen other side effects like neuromuscular complications. So depending upon the indication, you will have to decide the type of dosing you will be giving. In gram negative infection, you'll have to look at certain whether there are certain contraindication for this once a day dose or extended interval dosing. If there is any contraindication, you will do the conventional dosing, Q8 hourly dosing. If there are no contraindication, you will have to look at the following. So you can use either Hartford nomogram or the Urban Craig nomogram. And another thing is cystic fibrosis exacerbation. So what are these nomograms? So I'll be talking about in further slides. These are very important when you are dosing your aminoglycosides. And then if you are giving aminoglycoside as a part of synergy, that is in gram positive, and it is specially used in your endocarditis, you will give a lower dose, and it is depending upon and the dosage for enterococcus is 1 mg per kg Q8 hourly or 1.5 mg per kg Q12 hourly. And this dose, the infective endocarditis, it's the aminoglycosides, usually it is given, the treatment of infective endocarditis is 4 to 6 weeks, but usually the aminoglycoside will be given for only 1 week or 2 weeks, depending upon the type of the organism. In NTM, the dosing is NTM or the MTB, the dosage is amic acid 10 to 15 mg per kg Q24 hourly. So these are the contraindications I was talking about. So you can't use once a daily dose for pregnant females, neonates, severe burns, anasarca, ascites, in patients with meningitis, endocarditis, etc. And this is your Hartford nomogram. So what is this? So basically, this is a graph between, you can see the time between the start of infusion and sample drawing and the concentration. So what you have to do is, you initial monitoring, you just randomly draw blood from the patient 8 to 12 hours after the first dose. And then whatever the value you are getting, you just plot on the graph, in this graph. So if it is at 12 hours, the concentration which is achieved is 9. So you just plot on the concentration which it is 9 or say 6. So you can see it meets on the graph that is Q6 hourly, 36 hourly. So that is how you will determine the dosage interval for the patient. And this is applicable only when you give 7 mg per kg. And if it is you're giving a higher or a lower dose, it will under or overestimate your creatinine clearance. And for gentamicin, you can directly plot in whatever value you're getting in the TDM. Whereas amic acid, you divide it by half, and then you will be plotting on the graph. And you have to aim at the trough level less than 1 microgram per ml 6 hours prior to the next dose, so that it ensures an adequate drug-free window to minimize the drug accumulation in the proximal tubule. So the basic reason why we resort to the once daily dosing is to reduce the side effect, or that is the nephrotoxicity. They determine that the nephrotoxicity is much more when because of multiple peaks that is in the graphs. So that is why they have decided that if you are giving once a daily dose, that peaks are limited, and this will prevent the accumulation of the drug within the proximal tubules and hence the toxicity. And these are the whenever a patient is on aminoglycoside, you have to monitor his creatinine clearance, and if you are giving more than 2 weeks, you have to do audiometry as well. These are the various drugs and how you are going to dose based on the creatinine clearance. So this brings us to the next case scenario. A 52-year male comes to OPD with history of headache. His headache first appeared 1 month prior to the admission and worsened severely 6 hours prior to this. And this was accompanied by nausea and vomiting. On examination, GCS is 15. There is no neck rigidity, no history of fever as well. Plantars were bilateral flexors. On the day of admission, he had 1 episode of seizures. So for which MRI was done, it was suggestive of right posterior parietal cortico-subcortical lesion with extensive perilesional edema, suggestive of an abscess. So the surgical drainage was done and sent for culture. So what empiric antibiotic will you consider in this situation? Will you go for a ceftriaxone plus amikacin, since we are discussing the aminoglycosides, or any other combination as mentioned below? Please respond. Three, two, yes. So this is one of the important learning point. So whenever you're suspecting abscess, you have to look at the predisposing factors. You have to do brain MRI, and then based on the imaging, try to remove the abscess. And you have to start the patient empirical antibiotic with ceftriaxone with metronidazole. So one thing is aminoglycoside should be avoided in all the abscesses. Why? Because there is tissue hypoxia, WBC debris, anaerobic environment, local acidosis. So as I mentioned, in alkaline condition, your aminoglycoside acts the best. In acidic condition, it is not going to be effective. And because of all these factors, and as I mentioned, they are intrinsically resistant to your anaerobic as well. So all these factors will not allow your aminoglycoside to act, and hence in abscesses you have to avoid the aminoglycosides. Just avoid A. And one more thing, as I mentioned, aminoglycoside also does not achieve good levels in the brain. So what is the place of therapy? In where do you place aminoglycosides? So aminoglycosides are indicated in serious life-threatening gram-negative infection, complicated skin, soft tissue. Basically, every situation there is some role of aminoglycoside. So how are you going to determine? So in bacteremia, so it is effective as an empirical therapy, not as a monotherapy, but in combination with a beta-lactam antibiotic. By doing this combination, like ceftriaxone plus aminoglycoside amikacin, you have a broader coverage than fluoroquinolones. There was some improved outcomes and reduced because it's a protein synthesis inhibitor. It will reduce even the endotoxin release, and they're effective in MDR. And there have been some reduction in early mortality. And as I mentioned, the combination of beta-lactam or vancomycin is with aminoglycoside is recommended for streptococcal and enterococcal infection, endocarditis. And in HAP or VAP, again in combination with beta-lactam, aerosolized aminoglycoside has been used in cystic fibrosis exacerbation and in some chronic bronchiectasis, that is inhaled tobramycin is being used in that scenario. It is not recommended as a first choice or empiric choice in intra-abdominal infection, just because there are better alternative which is available, that is a ceftriaxone plus metronidazole can be given. In UTI, aminoglycoside has a very good role. You can give as a monotherapy in cystitis, and in complicated UTI, you can give for 5 to 7 days. And it is one of the second line drug in your treatment of drug resistant or MDR tuberculosis, NTM as well. And topically, neomycin has been used in infective wounds ulcers, burns, etc. Orally, before it was used in preparation of bowel and some in hepatic coma, but currently there is no role. Paramomycin is one of the aminoglycoside which is used as an anti-parasitic agent, and it has been used in EH, Trichomonas vaginalis, Leishmania, Cryptosporidium, etc. So next we have another case. A 23-year-old female presents with history of dysuria, increased frequency since 3 days. There is no history of fever, chills, flank pain, and vitally the patient is stable. Urine shows 50 WBCs and leukocyte esterase is positive. So what is the choice of antibiotic in this patient? So first and foremost, will you treat it? Will you treat this patient who is a 23-year female with dysuria and increased frequency? So what syndrome are you suspecting and will you treat it? No, we would not like to treat. So the patient has some symptoms and there is WBC is present. So you will be treating with the patient. So what is the empiric antibiotic you're going to use? Nitrofurantoin, fosfomycin, cotrimoxazole, or ciprofloxacin. So what is the commonest antibiotic which is prescribed in UTIs in your hospital or in this one? Nitrofurantoin, yes. Maximum of you are finding that you can treat with nitrofurantoin. So urine culture was sent and the patient's urine culture grew ESBL E. coli and which was resistant to your fosfomycin, cotrimoxazole, ciprofloxacin, nitrofurantoin. So what would you do now? Ceftriaxone, Piptas, Meropenem, Ertapenem, Amikacin, Ceftazidime-avibactam. So it's a ESBL E. coli. So what would you like to do? So what was ESBL? So they are resistant to ceftriaxone. If you had attended my previous webinar, you would know penem. So the patient, you can either treat the patient with Piptas because the patient is not having any, because it's an ESBL E. coli. Meropenem can be reserved for patients who are in frank sepsis and who are very sick. Ertapenem is a better drug than your carbapenem because it has a lower spectrum. But in patients who are not willing for taking 3 to 5 days of ceftriaxone or Piptas, and you have to give three injections per day. So instead of that, you can go for amikacin. And this is an uncomplicated cystitis. So a single dose of amikacin will do the job. So your aminoglycosides are known as poor man's ESBL treatment of choice. So now coming to the adverse effects. So first and foremost, aminoglycoside, the first and foremost you will remember is your nephrotoxicity. And why does it happen? The cells will internalize these aminoglycosides and there will be cellular necrosis leading to the activation of the apoptotic pathway, leading to total necrosis of your proximal tubules. And this renal failure is non-oliguric. So the patient may have normal urine output. So it is necessary you need to monitor the serum creatinine urine output as well as for the renal CAS. And this toxicity is due to the cumulative uptake in the proximal tubules. And next, the factors which are associated with increased toxicity are your use of concomitant nephrotoxic medication, patients who are on diuretics, contrast exposure, AC inhibitors, NSAIDs, cisplatin, and pre-existing renal disease. So most nephrotoxic aminoglycosides are your neomycin, followed by tobramycin and gentamicin, and least is your streptomycin. The next important adverse effect is your ototoxicity. And while your nephrotoxicity is reversible, your ototoxicity is irreversible. So it can be of impact vestibular or cochlea. So the vestibular ototoxicity is the most common, and it can manifest as vertigo, tinnitus, loss of balance. So if you're giving long-term aminoglycosides, so especially in patients who are on treatment for NTM, you will be giving for a quite long time. So you will always have to ask the patient if he's having any vertigo, tinnitus, loss of balance, and cochlear. There will be high frequency hearing loss. There won't be deafness, so you will not notice the
spectrum.
You will not notice the effect. The patient will not notice the effect soon, and also there is no correlation between your nephrotoxicity and ototoxicity, that you will tell that I am monitoring creatinine clearance. So the patient, once he is going towards nephrotoxicity, only he will develop ototoxicity. There is no correlation for that. So if you're giving longer duration of your aminoglycoside, you have to do the audiometry. And again, it is related to the peak level. The most ototoxic drugs are neomycin, kanamycin, and your amikacin. So this is the comparative toxicity of aminoglycoside. Pretty much all are at risk, obviously, and there are certain which are little more than the others. So the other adverse effects include rarely neuromuscular blockade, and they can unmask or exacerbate myasthenia gravis, and hence aminoglycosides and other antibiotics like fluoroquinolones, polymyxin, or macrolide should be avoided in patients who are having myasthenia gravis. So are all aminoglycosides same? No, they depend upon the organism. So tobramycin is more effective on Pseudomonas and Proteus than gentamicin. And for Pseudomonas, the best one will be, which is most will be amikacin, followed by tobramycin and gentamicin. Klebsiella, amikacin, gentamicin are more or less equal. Then again, on MTB, your streptomycin is the most potent aminoglycoside. And for your NTM like MAC, that is Mycobacterium avium intracellular, amikacin is the most active agent. So the susceptibility testing, so you would have seen different aminoglycosides reported for different organisms. So enterobacterials will be report of almost all the aminoglycosides, gentamicin, amikacin, kanamycin, netilmycin, streptomycin, whereas Pseudomonas and staph will have only report of gentamicin. So these are, I'm not going into details. So these are the various breakpoints, and you'll be getting the report. The important one which you need to understand is the HLAR, enterococcus for enterococcus. So in enterococcus, you will be testing only for high-level aminoglycoside. That too, specifically, you will be testing for high-level gentamicin and high-level streptomycin only. Why you are not testing the regular aminoglycoside? As I mentioned, it is intrinsic resistance, and you will always be testing and reporting these this test only in patients who are suspected to have endocarditis, or maybe say even at least bacteremia. So there is no point of reporting HLAR in urine isolates. So please do selective reporting. Don't report HLAR in all the cases of wherever you're isolating enterococcus. And also, as I mentioned, HLA, high level aminoglycoside resistance, it has no implication on the dosage of the aminoglycoside you're going to give as a therapy. So I'm sure all of you will be familiar with this. So basically, you're using a higher level gentamicin or streptomycin disc for looking at the susceptibility. So the last topic I'll be discussing is a newer aminoglycoside, plazomicin, which is available as injection of Zemdri. So the key attributes of this plazomicin, it's a novel semi-synthetic parental aminoglycoside, and as any other aminoglycoside, it will inhibit the protein synthesis, and it's a derivative of your sisomycin. And what is the important thing? It is it can inhibit more than 90% of the enterobacterials, which are non-susceptible to other aminoglycosides. They have low potential to develop clinical resistance with maintaining all the other aminoglycoside characters. So I'm telling there as just like other aminoglycosides. So how does it differ from other aminoglycosides? So if you can see here, there are three key structural modification which distinguishes One thing is there is no 3,4 OH which will protect against ANT and APH. There is no hydroxy ethyl group which will protect against the ASC, and there is N1 substitution with 4-amino 2-hydroxybutanoic acid, which will block ASC, ANT, and APH. So basically, all these are aminoglycoside modifying enzymes. So these structural changes are protected against these, and these AMEs are usually seen in ESBL and CRE producing organism. So by protecting against these, there is improved susceptibility over the traditional aminoglycoside, and it has been found that it is almost has a good susceptibility in most of your KPC, MBL, OXA, and other types of CRE. And it has been proposed for, it has received FDA approval for complicated UTI, including pyelonephritis, as well as BSI due to mainly Klebsiella and your E. coli. And because there is limited clinical safety and efficacy data, it has been as a reserve use for patients who are having no options for, no other options for treatment. So summarizing, so aminoglycoside, what is the mechanism of action? So it is a 30S protein synthesis inhibition, and they are bactericidal. So what is the important PK/PD parameters? It is concentration dependent with prolonged antibiotic effect. So what is the spectrum of activity? Basically your aerobic gram negatives and some synergistic action on the gram positive. What are the intrinsic resistance? It is intrinsic resistant to Enterococcus, Streptococcus, MRSA, anaerobe Stenotrophomonas burkholderia. What is the dosing? Usually the important thing which you'll be dosing is the daily OD dose, that is extended interval dosing. What are the things you need to monitor? You have to need to monitor creatinine clearance, look for CAS, symptoms of phototoxicity, and audiogram. So how are you going to do the dosing? And it is based on the type of infection, as I mentioned, whether it's gram negative, gram positive, or you're giving for NTM or any other infection like TB. And you have to use Hartford nomogram if it is 7 mg per kg dose, and Urban Craig nomogram if you're using 5 mg per kg dose. So what is the spectrum? I'm sorry, it's a repeat. So what is the treatment of high-level aminoglycoside resistant Enterococcus endocarditis with ampicillin susceptibility? We have already discussed. It is ampicillin plus ceftriaxone. So thank you. That was about the session. So let's look at some of the questions now. Sorry. Okay. Are there any questions? Anyone would like to ask any questions? Let's look at some of the questions in the chat box. So I'll be taking from starting. Okay, can we use for perianal abscess caused by E. coli? No. TOE or TTE, which is better for infective endocarditis? So first screening transthoracic echo only is done. And if you are still having suspicion of a vegetation or endocarditis, you can go for TOE. And TOE is in general better for your right-sided lesion as well as prosthetic valve. What exactly is low level and high level resistance? So as I mentioned, the MIC value is up to 64 in case of low level. If it is more than that for a beta-lactam, it is considered as a high level resistant to cell wall active agent. Enterococcus are intrinsically resistant to cephalosporin. Then why ceftriaxone? As I mentioned, it is because of the synergy only. Otherwise, you are not going to treat any enterococcus with ceftriaxone. HLAR can we report on cellulitis? So the patient, if at all cellulitis, ideally it should not be reported. If at all patient is developing suspicion of infective endocarditis is there, then so indications for monotherapy of aminoglycoside, basically current indication which I could make out is one is you can use in cystic fibrosis exacerbation, then UTI, uncomplicated UTI. Then is dapto good for VRE, Enterococcus faecium? Yes, if there is no other option, dapto can be used. Is there any alternative for drug monitoring except blood monitoring? TDM only is the thing which you can do. There is no other way you can. Then what's the rationale behind for testing high level gentamicin? Basically, when you give a high level, Dr. Selvi. Dr. Selvi, you can speak. Susceptible strain of enterococcus cellulitis, only ampicillin or penicillin is enough. If it is susceptible, yes. Why are you going to combine with Genta for that in a patient who is having no other indication? No, you can give it a monotherapy. One more time regarding gentamicin, ampicillin, sulbactam. So, okay. So if your aminoglycoside, that is HLAR, is susceptible and your penicillin or that is your beta-lactam is susceptible, then you will have a synergy. So you can give this as a combination. So you can give penicillin or ampicillin plus gentamicin. Next scenario, you have HLAR susceptible, but your penicillin is resistant. Once your penicillin or ampicillin is resistant, you have to look for whether it is high level or low level resistant. If it is low level resistant, you can give a higher dose of your beta lactam, then combine with your gentamicin. If it is high level resistance, there is no point in doing this combination. So you'll have to go for vancomycin combination with gentamicin. If it is HLAR resistant only and your beta lactam is also resistant, is susceptible, in that case, you can give if both are resistant, what you're going to do? Then you have no other option. Don't use this combination. You give daptomycin with daptomycin in combination only. HLAR is only for enterococcus. Yes, HLAR is only for enterococcus. And what is the role of aminoglycoside in osteomyelitis? It is one of the good drug. It has good penetration into the bone. The only thing is osteomyelitis has a longer duration of treatment. So it is not generally preferred. Then what are we missing when we don't treat, when we don't report a high level streptomycin or gentamicin resistance? The clinician will have to be blind and give they'll be giving this combination even if it is resistant. So unless there is, if the patient is not having endocarditis, So you can, I mean, you're not necessarily missing anything, but if the patient has endocarditis, you're missing one of the important treatment of choice. Against Pseudomonas, your final call tobramycin or amikacin. Tobramycin in general, the hospital does not have, so we use amikacin only. Only in IE by enterococcus, no other infection caused by same organism. I didn't understand the question. I have answered this. In case it is VRE, there is no other option. Daptomycin is a very good option. And there is also this seesaw relationship between vancomycin and dapto. When the susceptibility of vanco is low, resistance of vanco is high, dapto will be more susceptible. And daptomycin also you will not be going to give as a monotherapy. You will be giving in combination only to prevent the emergence of resistance, and it is usually combined with the beta-lactam ampicillin. Any difference in resistance mechanism in Genta and amikacin? The resistance mechanism is the same. It can be as any of it, but I have not gone in total detail, but also you can determine based on the type of AME. Some AMEs is associated with resistance only to gentamicin, whereas some AMEs, when they are expressed, there will be resistance to gentamicin and amikacin. So that is why you will be seeing in the report various susceptibility, like sometimes amikacin sensitive, genta resistance, and so on. HLA testing is done only in enterococcal, and it has only in enterococcus, and it has implication only in endocarditis. There is no other infection which it will have implication on. Also, one more implication can be persistent bacteremia whenever due to enterococcus. So in that scenario, you may have to look at HLA before starting the patient on the combination therapy. So in bloodstream infection and basically your bloodstream infection, it is recommended that you report your HLA, and in urine and your pus sample you can avoid. Dalfo, I have not used it, but again, quercetin, dalfopristin, it is intrinsically resistant in case of fecalis and sensitive only in case of ischium. Any role of tobramycin therapy in skin and soft tissue infection caused by Pseudomonas aeruginosa? You can't use it as a, like in general, avoid as a monotherapy any of your aminoglycoside. If you are looking for local site infection, you can use neomycin ointment or anything for the treatment of local infection. Otherwise, generally avoid it. Okay, if there are no further questions, let's end it. So Dr. Selvi, do you want to ask any question? Uncomplicated UTI, nitro or aminoglycoside as monotherapy. So you can use, so if it is susceptible, you will be going for nitrofurantoin. And depends on also, if you're giving as an empiric therapy, you should have your local antibiogram determining how much % of your isolates are resistant to nitrofurantoin. If it is like more than 50% of your isolates are resistant, there is no point in giving nitrofurantoin. And also one more indication is uncomplicated pyelonephritis. You can also give aminoglycoside as a therapy. Okay. Thank you, everyone. So I'll be sharing the feedback form. Please do fill, and yeah. There is no cutoff as such for the reference. I'm telling you should look at the susceptibility percentage. In general, if it is less than 50% susceptible, there is no point of giving as an empiric therapy. That means 50% of the time your patient will not be responding to the therapy. Thank you, everyone.